Nick, and I'm one of the dosimetrists here. I'm going to talk about head and neck BMAT planning. So the presentation outline, we're going to go through simulation, contouring, planning, and treatment. Here at Stanford, we utilize TrueBeam and reflection for our head and neck patients. We'll get a little more into those later. For simulation and setup, we start off head first supine, arms down by the side, shoulders down, and then the neck is slightly extended so we can reduce skin fold. There's custom immobilization here. We use things like pillow and knee sticks for comfort, long mask, clarity board. This is for stability and reproducibility. We want to be able to reproduce the setup. Like Dr. Gensheimer said, it's 3 millimeter margin, so we have to be real precise with our treatment. Usually for post-op, well, there'll be wire scars for where the surgery occurred, and if it's superficial, then we may use 3 millimeter bolus. For basic tongue patients, we use a custom tongue stent to spare the palate, push the tongue away as well. During simulation as well, we would take a CT with IV contrast. We would also take a PET CT in the same position, and if there's MR available, then we'll import and fuse that. These things help us delineate the tumor. And if it was a post-op scan, then we would, and there's a pre-op diagnostic scan available, then we'll bring in and fuse that as well to help find subclinical disease. So here you can see the PET, it's glowed up right here. This is where they would contour. There's usually 4 different dose levels, as Dr. Gensheimer said. Sometimes there's 2, the main one, high risk PTV 70, there's PTV 60, PTV 56, and PTV 52. When we create tuning structures, it's very important because this is what we tell the optimizer how to dose. We usually start off by cropping all the PTVs away from the skin, 3 millimeters, and we use this general rule of thumb, 2 to 3 gray per millimeter drop off. So to create a tuning structure, say we want to create tuning structure PTV 52, we're going to go from 70 gray to 52, and that distance divided by 2 to 3, 6 millimeters. So to create PTV 52, we're going to have to crop the original PTV 52 from the PTV 70, 6 millimeters, and then we're going to have to crop that 3 millimeters from PTV 60, and then about 2 millimeters from PTV 56. You have to do this for every dose level, so that we can push the high dose into the primary PTV and then still cover the low dose. So there will be 4 different tuning structure PTVs to tell the optimizer where to put the dose. For OARs, there's plenty of OARs in the head and neck region. The important ones are brainstem 45. Brainstem 45 max. Because there's so much OARs, there's going to be a lot of sparing, so the dose is going to go kind of like a butterfly shape. A lot of these OARs are lateral, anterior, posterior. Some important ones include the spinal cord, the parotid, the pharynx, but we'll get more into that when we talk about dose distribution. For contouring, we have Limbus AI that helps us, but traditionally, contours are done by dosimetrists, residents, and physicians. Even though we do have auto contours, it's not perfect, so we do check them, but they do help with efficiency. So we have to create the OARs, and then we have to create tuning structures for the OARs as well. You can see on this slice right here that the parotid kind of overlaps with the PTV. So we like to crop our OARs with a margin from the PTV. This way we can push dose in between this area right here, so we don't lose coverage, but still able to spare these OARs. It's a fine line, it's a fine balancing act in the optimizer between covering the volume and sparing the OARs. And you can see through here that the pharynx is cropped. Not necessarily don't need to crop the spinal cord because it's far enough, but there's a lot of overlap and there's a lot of OARs with head and neck planning. We also utilize rings, and and tuning structures. So some of the rings that are important are the 45 ring and the 35 ring, and these rings are just made to keep the high dose conformal. And this is the same rule that applies to the PTV tuning structures. Like the 45 has to be cropped variably, so it's cropped differently from the high dose than it is from the low dose. You can see here that it is cropped about 13 millimeters from the PTV 70 compared to about 7 from the PTV 56. The 35 keeps the 35 gray conformal. The post avoid, this is important because we want to spare 30 gray from the back of the neck so we can save the patient from hair loss. And over time, the patient will lose weight during the treatment, so there'll be less tissue, meaning more dose to this area. So we want to push as much dose off the back as we can. We also use a midline kind of structure to prevent the bridging between the 35 gray. And this bridging is important because it spares the midline OARs like larynx, glottis, pharynx, and other OARs in that area. With head and neck, there's a lot of dental implants as well, which may cause streaking and beam starvation. Our job is to contour these implants and then override them with the titanium. And with the streaking and the starvation, we have to contour these, the missing tissue, and override these to the muscular tissue for a more accurate dose depiction. For planning in Eclipse, we use acros, which is a more accurate dose calculation for all interbases, takes in the heterogeneity of bone, air, and tissue. And then we also use reflection X1, which utilizes collapse cone compilation. So for setup, we like to put the isocenter in the middle of the field for head and neck. And then you can see here that the collimators are turned differently. These two have horizontal collimators, but they're different in terms of collimation angles. One is 15, one is 34. This is the third one. It's turned 80 degrees so that the MLCs can go vertically. This helps spare the midline structures. You'll see that these MLCs come through the midline and are able to block the midline structures a lot better. And if you see here, this is all three of the fields put together. And the different collimation prevents dose leakage in between the MLCs. So the different collimations are important. And depending on how many dose levels there are and how big the tumor is, we may even use four beams or sometimes even 2 beams. So inside the optimizer, we have 4 MR levels. MR1 is usually where I'll start pushing dose into the PTV and getting my coverage and telling the rings to stop the dose from spilling. So you can see here that all the objectives are put on the TS PTVs because we are using the TSs to optimize too. If I put in an upper constraint in the original PTV, say 52, then it may be contradicting with asking for coverage in the high dose overlap. Over time, over the course of the MR, it starts pulling from more angles as well. So in MR2 is when I'll start asking for OAR sparing and start pushing really hard. And then MR4 is where I'll clean up the hot spots. For reflection setup, it's pretty similar in terms of isocenter placement, except for there are some rules like we can't put it out too lateral and we have to stay within 14 cm. The treatment is a bore, so there's less free movement for shifts. And here's a reflection optimizer. It does a pretty good job. Sometimes we come up with an even better plan. Homogeneity is pretty good, and the possibility. It also has some pretty good tight dose gradients. But this is a lot more prep work as well. We can't contour, and we bring in all our structures in from Eclipse, so we really have to do early prep work for reflection. So the dose distribution, a couple things that the doctors look for. Each PTV level needs to be covered by 95 prescription dose. The homogeneity, we usually keep the hotspot around 107, and we want to minimize the 105% as much as we can. We want to keep the high dose conformal around the targets and keep the intermediate dosing control, and of course, we want to spare the OARs. We're going to get this beautiful butterfly shape distribution because a lot of the OARs are lateral, anterior, or posterior. Like the parotid is lateral, the oral cavity is anterior, the spinal cord is posterior. Getting a sharp dose gradient is important around the parotid as well. Sometimes we won't be able to spare one. Say the PTV high dose is on one side, but it's important to at least spare one parotid because they do contribute to salivary production. As Dr. Gensheimer said, salivary is important because that can lead to dry mouth, which makes it uncomfortable for the patient to eat, which will lead to the patient losing weight over treatment. So we also want to keep the 45 gray conformal so we can spare the pharynx, keep the 35 gray conformal, and keep it from bridging so that so that we can spare the midline OARs well. And then we also want to keep the 30 gray posterior because we want it to wrap it securely around the spinal cord. This will prevent hair loss in the back of the neck. And then, like I said before, the patient's weight loss over time. The patient will lose weight over time during the treatment, putting more dose in that area. We also want to keep an eye on the 20 gray so it doesn't cover half of the oral cavity. So here's a depiction of the dose. You can see here that there's kind of a butterfly already starting to shape, but right there. But you can see that the dose is nice and carved around the spinal cord posteriorly. This is the 30 gray line. You can see we're carving out on the submandibular. You can see here that we do a pretty good job breaking the bridge, sparing the larynx and the glottis. But we're preventing that 35 from bridging. Even in this case, the 30 from bridging. That's pretty good. And we're keeping the high dose is conformal. We're not letting it spill. And the 45 is pretty conformal right here as well. And you can see that the 70 gray is contained in the high dose, and there's no 70 gray or 60 gray in this lower PTV region. And this is just a bigger picture we can use to go back. You can go forward. Here's the beam's eye view of the gantry movement and the collimators moving. So you can see the horizontal ones do a good job dosing the target. But I think the most important one is this vertical one. You can see here that the MLCs do come up in between this open space and do a good job of blocking this area out while still giving dose to these regions. And here's a deviation. I know there's a lot to look at, but I think the important thing is to look at the PTVs, like the PTV 70 here. We're getting 100% to 95% of the volume, which is the goal. We're getting 100% of the prescription for the 60. We're getting it for the 56, and we're getting it for the 52 as well. So we're fully covering our target volumes. And as far as the OARs, we're meeting all of them in this case, but typically sometimes you won't meet them, but we're trying our LARA for everything. And in this case, we're meeting both parotids, but usually sometimes the one parotid may be higher than 2016, but we usually push that as well. So here's a question. What is the dose limit for the spinal cord? Pretty good. The dose limit for the cord is 45, but we do still try to spare it to 30, 35, because over time the patient will lose weight, and that would cause more dose to that area. What's the dose limit to the parotid? We're looking for a mean of 26. Pretty good. There you go, a mean. There's not really a max dose to the parotid, but the main thing is volumetric. So we also have an in-house auto planning script made by one of our physicists here. It does a pretty good job. The iterations are pretty good. It helps us in terms of workflow and efficiency. Sometimes we do have to go back and clean up a little bit, but overall it's a pretty good written script. On the day of the treatment, we usually do daily KV and align to the bony anatomy, and then we'll do weekly CBCTs just to make sure that the tumor hasn't shrunken or the patient hasn't lost weight. You can see here that the orange is the CBCT and the blue is the original planning sim. And you can see that the CBCT, the patient does not fit into the sim anymore. And the PTV is now outside the body. It doesn't line up too well. So if this is the case, then we'll take another cone down. We'll make a cone down plan. We'll resim the patient, and then we'll replan for the new scan. So beam arrangement is important. Tuning structures help control dose, and utilize the differential margins to create conformal homogeneous plans. I don't think head and neck planning is too difficult, but it does require a lot of prep work, just so we can tell the system where to put dose and how to shape the dose. And that's it for my slide.
Very nice, Nick. Good job. I'm opening the floor for questions. So thank you, Michael, for staying in. I saw that you answered already many questions in the chat. Any questions that you want to ask additionally?
May I?
Hello. I'm sorry. Kirill, you first.
Okay, you first.
Thank you very much. So thank you very much for both lectures for their wonderful lections. And I have a few questions. First of all, about the boost. What you prefer, simultaneous integrated boost or sequential? Because the patient lose their weight during the treatment, and the shape of the neck could be lower, and we need resimulation. So the awareness of the missing the targets in case of simultaneous integrated boosts is very high. What would you recommend?
Yeah, that's a good point. Well, we typically do integrated boost because you get lower dose per fraction to the normal tissues, which is nice for the normal tissue sparing. And then it also just makes it easier for the dosimetrist, since they can optimize a single plan and get really nice reduction of hotspots on the brachial plexus and this sort of thing. In terms of the weight loss and all that, yeah, that's a good point about the simultaneous integrated boost. You know, we do have the resources. We're lucky enough to be able to do a new simulation and a new treatment when they have weight loss. I guess the other thing is that our dosimetrists prefer to, even if we're going to do a sequential boost, our dosimetrists prefer to do the boost plan up front so they can kind of optimize the initial and boost plans together. So they're already doing that extra work for the boost plan anyway. So I don't think that's a big reason to do sequential, but I don't think either. It's not wrong to do either one.
Okay, thank you very much.
We love sequential. It's just so much easier, and you can control the low dose spillage much better.
Wait, you mean simultaneous integrated boost? You mean?
Oh, sorry, simultaneous SIB. Yes, sorry.
That was the first time I heard one of the physics.
No. We love SIB. We love SIB. SIB.
Okay, and another question. I noticed that the patient with retractors. Yes, some retractors. It's is it 3D printing, or maybe I don't know, some
Oral stent. It's an oral stent.
Oral stent. And how is it making?
Yeah, we had a lecture by Laurie, so he talked about making patient-specific 3D printed oral stents.
Okay. Is this the devices from that lecture? Okay, yeah. Thank you very much. And about the supportive care, you present the slide, and actually about feeding tube. You prefer to do it when it needed or upfront the treatment, starting treatment?
Yeah, so here we almost always do them as needed. That's partial, well, there are two reasons. One is that with our small PTV margins and reduced elective dose levels, and just generally small CTV margins that we tend to use, many of the patients never need the feeding tube, so it's nice to avoid it. The other reason is that our speech language pathologists think that it's better to keep the patient swallowing, sort of forcing them to swallow food during treatment in liquids. They think it keeps the swallowing muscles working better and reduces fibrosis and this sort of thing. I'll tell you, there's not really a trial or anything that proves that. So I'm always a little bit nervous when I say that because I'm not actually sure if it's really true. But anyway, those are the two reasons.
Okay, thank you very much.
Yeah.
Thank you.
Kirilo, you want to ask a question?
Yes, I want to ask about reobtaining patient. You have some criteria because we do every time imaging every day or every week, and we have some shift. And which criteria when we reobtaining and when we can treat as in first plan?
Yeah, so good question. So let's see, we do daily imaging with KV films and then weekly cone beam. The weekly cone beam CT is just, it's not really to line the patient up that day. It's more just to make sure that generally where the tumors are covered by the PTV and they haven't had too much weight loss causing the nodal volumes to shift outside the PTV. In terms of when do we need to do a replan? Yeah, good question. I mean, some of the head and neck physicians used to always do a mid-treatment CT scan, like every single time, I think. And I tend to not do that because it's not a great use of resources if a patient hasn't lost much weight. So I use the cone beam CT a lot. And then if I'm noticing they've had a lot of weight loss on there or they're not lining up well, we'll do a new CT. And then generally I'll have the dosimetrist calculate the old plan on the new sim CT, and we'll see a lot of times the old plan works fine. Even if they've lost a lot of weight and the neck moved in, as long as the PTVs are still covering the areas, usually the plan still looks fine. So sometimes you don't always have to make a new plan.
Would you have
Thank
to
you.
redo the mask though? Because the patient would not be lining up as precisely.
Sometimes,
You have
not
3
usually for weight
millimeter
loss,
margin.
actually. No, not usually for weight loss because the AccuForm head holder usually fits pretty well still. And the facial features, your nose doesn't change, your chin doesn't change much when you lose weight. So you're still locked in pretty well. So usually we don't have to make a new mask, even if we do a resimulation.
Mhm.
And the second question, how it technically works, because if we see a patient have a big shift and we are reobtaining, we need some time to make a plan. And we make a pause or we treat patient with ORT plan. And 1 or 2 days we spend to make a new plan, and after that we continue treat with new plan.
That's exactly what we do here. So we continue with the old plan. Usually it's not hopelessly bad. Usually there might be a little bit of under coverage of the edge of the tumor or something like that, but it's still within the lower dose PTV. So it's fine for it to get a little bit less dose for a few days, and then you start the new plan. As I mentioned in the answer to the other question, as you know, treatment breaks are pretty bad for head and neck cancer. So I would not recommend stopping treatment while you make the new plan.
We
Thank you.
usually have a boost plan ready within 3 days.
Yeah.
Any other questions?
Actually, I need to run to clinic, so I'm going to run
Oh,
off.
yeah.
If you have other questions for Nick and Natalia, go ahead. Thanks so much, everyone. That was fun. See you later.
Thank you, Michael.
All right.
Any questions for Nick in terms of planning?
Yeah, hello. Are you hear me?
Hello. Yeah, we can hear you.
I have a question to Nick. Does it happening sometimes the doctors don't like your plan? Maybe where you started your career, I don't know. And if yes, what is the main reason? What you maybe you forgot something to do in plan or something else?
There's always a little bit of back and forth, you know. If I can't come up with the plan, we'll talk it through, and then sometimes there's compromise. And there's other things that I can try, like add another beam. But they do. I'm pretty lucky that our physicians do a good job explaining what they want, and you know, just a nice back and forth. So.
Yeah, maybe in the beginning when you're just starting, right? You figuring out what the physicians like, but at some point you learn what needs to be done and how the plan should look like.
Right. You slowly figure out what different physicians want, and then you're able to adjust to. You figure out what they you kind of find out what they want, and then you just learn from there, and then moving forward you are able to know.
Yeah, Nick is excellent planner.
Thank you.
Yeah, thank you.
Thank you. Okay, we'll finishing our session for today. Next session is next Wednesday on protons. So see you later. Bye-bye. Thank you, Nick.
See you guys.